Hey guys, how are you doing today? This is Riyad again, and today I'm gonna basically broadcast for you the third lecture of cardiovascular pathology, which is question types of USMLE Step 1 series. So what we have for today, let me okay, I already highlighted some stuff. So we have 65, so it's mean older. If you remember, this is our how we will read the questions. You will get the age, maybe gender, sometimes it's important, and chief complaint, and please the symptoms, whether it's acute or chronic, right? This is usually the approach. Maybe you will need one or two words of past medical history. So this is 1, 2, 3, 4, 5, always. So you get the age 65, you get male, you got what else? It's shortness of breath, acute dyspnea, please. So it is sudden onset. So you got this 1, 2, 3. So you are now here. That's it. You almost made it. So sudden onset, shortness of breath. Look at the significant past medical history in this patient. It's very, very, very interesting. So he has history. Boom. Am I? When? 2 days ago. He just discharged from the hospital 2 days ago. That's mean my topic today is myocardial infarction. That's it? No. Complications. So in other words, complications of myocardial infarctions. So what next? After four or five lines, and I told you cardiovascular questions usually have a lot of lines. Usually it's really long. So you have apical holosystolic murmur, right, which is big time here, plus you have crackles. Now elevation ejacular venous pressure, it's okay. Blood pressure low, it's okay. Heart rate high. Why I'm saying these okay to these signs? Because these are really the signs that are general. It will really not significantly affect your diagnosis, because this is usually non-specific tachycardia. This is another non-specific one. So all of these usually non-specific. So I'm not to skip it, but I will discuss blood pressure and this. Now again, let's go back to the specific ones, guys. So you have big times here, murmur, crackles, right? And acute shortness of breath, which is really not hard. And the topic is basically post-MI complications. Now, how I will make it? Really, honestly, how we will make? Let me make it. Let's hope. I'm not sure if this. I think thinner. Yeah. Okay. So let's see how we'll approach this question, guys. You are ready? So let's make a table. Actually, a diagram first, which is, I like diagrams. So what is the diagram? The diagram basically talk about MI shortness of breath. After MI, the patient have shortness of breath. And you need to know when the shortness of breath started, within 1 day or within 3 to 5 days, because it's different, guys. If it is within 1 day shortness of breath, then what is the next questions? Always, when is the patient have shortness of breath, what you will examine? What do you think? If I have shortness of breath, if a patient came to you with shortness of breath post-MI, or just shortness of breath, what you will examine? It's really easy. Go to the lung, right? So you will examine the lung. So in the first day, you will hear the lung is crackles. So you can say crackles positive, murmur negative, or maybe you can say no murmur. Sometimes people, they don't like me when I say positive, negative, they don't understand. So you can say no murmur, right? So this is the first differential. Now the second differential, which is really big category here, it's after shortness of breath within 3 maybe to 10 days. Sometimes they say 3 to 7 days after MI, which is 3 differential diagnosis. So this is how we'll approach it, please, because I don't want to really want you to confuse. Shortness of breath after MI, if you will within 1 day, plus the crackles, no murmur. And within 3 to 10 days, again, what you will hear, go to the lung. Now, in the lungs, you have 2 differential here. If you hear crackles in the lung, a plus murmur, then this murmur is usually apical murmur, right? Then for this murmur, it's really interesting. You need to know whether it's radiated or not radiated. So if it is radiated murmur, right, or not radiated. So hopefully the screen is enough. So if it is radiated, basically the answers will be mitral regurg. So it's MI, regurgitation, right? Another The important pathology of mitral regurgitation in post-MI is papillary muscles rupture or papillary muscles dysfunctions or papillary muscles just ischemia. So you can say papillary muscle dysfunctions. Right, if it is not radiated, where is the problem? You hear a murmur apical, but not radiated. Although really this is not specific, but for pathology-wise, for step 1-wise, they like it. I don't think really they will ask these details. There is another one important details about these murmurs, but I don't want to go further because I don't believe this is important. So, but I believe you have to know if the murmur in the in the apical region, which is usually 4th to 5th intercostal space, not right. Let's assume it's not radiated. What's your differential, guys? Where is the problem? The problem in the septum. So usually the answer will be VSD, which is septum rupture, right? So I hope these are clear. Very high yield, guys. Big time, honestly. Very, 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 very high yield. After MI complications, 3 to 10 days, go to the lungs. You will see the lungs crackles plus murmur apical, radiated. Boom, your answer will be just mitral regurg or mitral valve or papillary muscle dysfunctions. Now, not radiated, this is VSD. So that's it. Now, what you need? There are more basically. Look at the lungs, which is the 3 to 10 days, but the lungs, boom, it's clear. Wow. You know, I don't know, really, I'm gonna tell you. Clear lungs with acute shortness of breath, not too much differential. Really. The big differential, clear lungs, shortness of breath, for you always in your mind, please, well, still you have rupture problems, which is basically myocardial, right? Wall rupture means we are talking about tamponade. So here the answers is tamponade. Right. Very high yield, guys. Really big time. Very, very, very high yield. Cardiac tamponade. So cardiac tamponade, which is basically because of the cardiac wall rupture, the blood will escape from the wall into pericardial space. So the blood in the pericardial space will compress the heart. This is cardiac tamponade. All right. So there is another pathology basically for tamponade, but I don't think it's important now. So if you hear clear, if you didn't hear murmur, which is basically on the right side, and the lung is totally clear, so your answer is just myocardial wall ruptures. Now, what you have so far? You have guys around 3 differentials or 4 differentials. So for this differential on the right, on the left side, or the left side differential, sorry, I will go up. All the left side, which is basically from here, look at that, all the way, boom. Even one day, crackles positive, no murmurs. What is the big category? Do you think what is the big category or the disease? Not the disease. Yeah, because the disease basically it's mitral regurg, VSD or massive necrosis. By the way, the problem here in the first day, why the patient have crackles and no murmurs? This is basically due to massive necrosis. And because the massive necrosis, there is significant decrease in cardiac output. Why? Because there is no contractility. Significant decrease in contractility, so decreased cardiac output. So all of these 3, let's make it kind of, maybe take our acute. Basically, it's not acute. I mean pulmonary edema, right? All of these 3 is just pulmonary edema, guys. Very high yield, big time. People have a problem to say or to connect pulmonary edema with valvular heart disease, basically. They don't know. For some reasons we don't know. Maybe nobody teach us that, maybe in medical schools before or whatever, in these details. But really, how the murmurs present very high yield, and it's really, really easy. Murmurs, guys, usually present as shortness of breath. Usually, patient presents as shortness of breath. Usually, especially if it is acute. So here, whenever you have acute, which is basically VSD or basically mitral valve regurg, they are presented as pulmonary edema, right? They are presented just as pulmonary edema. So if it is massive necrosis, also presented as pulmonary edema. Now look at the right side, which is very easy to make it because there is no way to get it wrong. The right side, basically the lungs is totally clear and there is no murmur, so it's really tamponade pathology. Guys, we're done. Really, we're done. Now, what you need pathology-wise? Maybe you need some spices. 1 day or 3 to 4 days, 3 to 10 days, if you will tell you what is the pathology here. Is it necrosis? It's rupture. Right? It's interesting. I mean, now what is the cell? Macrophages. Basically the stages of cardiac necrosis or myocardial infarction. Stages of myocardial infarction, which is basically in whole of pathology book, which is very hard. I mean, the consequences of the stage, they usually say it first, in the first 4 hours, maybe nothing. Maybe 8 hours, you will get contraction necrosis. Later, basically, the neutrophil coming up. And later, macrophages. Later, fibroblasts. And this basically details microscopical features. Honestly, I don't think this is really high yield. Yeah, I know. A lot of people argue with me, but really, I don't think this is high yield. The high yield things is how you correlate the medical, which is basically the clinical symptoms, with the pathology. So pathology here, rupture. Pathology here is macrophage. Look at the 1 day. What is 1 day pathology? Necrosis. What is the cell? Neutrophil. So neutrophil play a role in the 1 day, right? This is how you'll make it. Now, one more thing. You remember when I told you in the beginning, hey, don't really pay attention. I mean, you will pay attention to the blood pressure low and heart rate high, but this is really non-significant. Why? Because you cannot differentiate. For all of these three, what I will add to the shortness of breath plus blood pressure low plus heart rate high. That's it. I made it for all of them, right? So that's why, guys, you cannot differentiate. I mean, if he will tell you from the beginning, hey, it's shortness of breath, decreased blood pressure, decreased heart rate, that means really nothing. I mean, no, hey, don't get me wrong, that means nothing, but I mean, you cannot differentiate. All the people shortness of breath with decreased heart rate, decreased blood pressure, or decreased heart rate. But you need tricks. So you need to look for the murmurs, you need to look for the lungs, whether it's clear or not. Clear lungs, tamponade. There is another differential diagnosis for a clear lungs, which is RV infarctions. I don't think RV infarction is important in step 1, honestly. I didn't hear it. I didn't hear about RV infarction in step 1. Maybe I will talk about RV infarctions later. But what I need to add, tamponade, I need to add one more thing about the pulse. Anything about the pulse and tamponade. Its characteristics, it's maybe not really, it's not just specific for tamponade. It could happen into other diseases, for other diseases. But whenever you will hear tamponade, maybe he will tell you something about pulsus paradoxicus. Alright, tamponade is big a problem. We will talk about that when we will go to pericarditis. This is not pericarditis talk. But now, why I'm talking about that? Look, from the tamponade, you can tell me first, it's a clear lung, it's hypotension, it's pulsus paradoxicus, it's heart rate increase, maybe even JVP increase, right? Which is, there is a kind of triad. Pick a triad. You don't need to know the name. But I mean, that's it. For papillary muscle dysfunctions, you get the crackles, you get murmur, and you get 3 to 10 days. So this rupture pathology. For VSD, which is septum problems, you get crackles, you get murmur, you get 3 to 10 days. Right? So that's it, guys. So this is the way how you will discuss. This is the way usually how you will answer these kind of questions. You have to get some approach. Yeah, you have to get some approach. Now look at the answers. Basically, myocardial wall rupture. What is that? Tamponade. What is the things against tamponade here? I mean, if you will go to the diagrams, what is the thing against tamponade? Tamponade, there is no murmur. I told you there is no murmur in the clear lungs. So basically here you will say clear. I will repeat it again. It's good to repeat it. Clear lungs and negative murmur. Right? Now, myxomatous degeneration of mitral valve, boom. This is usually asymptomatic. Guys, this is mitral valve prolapse. MVP, prolapse, always the answer for prolapse is myxomatous degeneration. The valve just degenerated. Usually young, female, no symptoms. So mitral valve prolapse presentation, usually you need to know these keywords. Young, female, asymptomatic. Usually you'll find it by routine follow-up. Big time problems regarding the murmurs. I mean, big time is important regarding the murmurs. Really, I will discuss about mitral valve collapse again in details when we'll go to valvular. Now, papillary muscle ischemia, boom, maybe this is the answer of your questions. Where is it? Yeah, papillary muscle ischemia, which is basically mitral regurg. And he told you about the murmur. He told you, hey, the murmur that's radiated, so it's really typical. I didn't put here in my question. This is basically my question, which is, if you'll see, even the word's really easy. I didn't put VSD because I think VSD with mitral regurg will be really hard for step one. So I didn't put VSD. So it's papillary muscle ischemia, which is almost papillary muscle dysfunctions or rupture problem, which is 2 days. Hey, this is 2 days after hospital admission, that the patient is already hospitalized because of MI. So that's why we assume that we are in a period between 3 to 10 days. Right. Now, immune-mediated pericardial disease and inflammatory pericarditis, which a lot of people love it, and maybe they will choose it. At least my student in the beginning, when they came, always they love pericarditis. I don't know. Oh my God, they always make me crazy. Always the answer, pericarditis. I'm so excited. So it's okay. Pericarditis usually chest pain. Please. Usually pericarditis, chest pain. I mean, the problem in pericardial tissue, pericardial tissue either usually it's a problem with pericardium, either inflamed because of immune-mediated disease or inflamed because of myocardial necrosis. So I will talk about pericarditis also maybe later, and yeah, maybe within this video. Yeah, maybe I think it's wise to talk about chest pain after MI in this video too. The category here will be chest pain after MI. Right, will be chest pain after MI. Well, I look at these three things. Usually, category is shortness of breath after MI. However, I talk about MVP. MVP is not usually asymptomatic, right? Usually asymptomatic. But I mean, this third one is shortness of breath. This first one is shortness of breath. Yeah, maybe this is more accurate. And the second one is asymptomatic. The last two is chest pain. You got it, guys? This is how you'll make it. Now, again, repeated that with me. First one, which is first option, shortness of breath. Now, the second option, asymptomatic. Third option, shortness of breath. Fourth option, chest pain. Fifth option, chest pain. So there is no way to confuse. Either you will get one, so either you will choose one or you will choose a three. Because you have only two causes for shortness of breath here. You have myocardial wall rupture shortness of breath, and you have mitral papillary muscle ischemia shortness of breath, right? So that's it. You don't need to confuse, really. You don't need to confuse. It's really so easy. So while with pericardial disease, you get chest pain. Now, I'm not sure. Give me 1 second. Let me see if I have time to go over. Yeah, I have time to go over pericardial disease, which is basically chest pain after MI. So this is the first line, which is this one. Right? We discuss it together. This is MI, shortness of breath, right? There is MI, chest pain. I mean, patient after MI will come with chest pain. And this is really high yield too. So MI, right? And after MI, patient came with chest pain. Now duration. It's very high yield again and again and again. Now if it is within 1 week, right? 1 week after MI, chest pain, or maybe you can say 1 to 2 months after MI. Now 1 week after MI, you have two differential, guys. Either recurrent MI, or look at the other differential. It's really easy. This is the myocardium. So myocardium. Now this myocardium, look at the necrosis. It's really big time necrosis. Very, very bad. All of that necrosis. Now it's really easy because after myocardial layer, what you have? You have pericardial layer. So this is the pericardial layer, the one, the green, pericardium. Now, and this is the myocardium, and again, let's make the necrosis more. Let's make it bad. So basically, the necrosis just comes and attaches to pericardium. So what's happened here? What do you think? What happened? Just pericarditis, secondary to myocardial necrosis. One of the very high-yield questions. Very high-yield questions, pericarditis, really. So it is basically, your answers will be pericardial, right? Inflammation over myocardial necrosis. So that's it. Chest pain, 1 week after MI. There is a lot of differential between it and recurrent MI. Recurrent MI usually will see recurrent enzymes positive. Usually CK positive, which is creatine kinase will be positive, will be start to increase. Troponin will start to increase more, also will be raise. But CK, there is a trick about that. Hopefully I will have time to tell you about this trick, which is recurrent MI. Whether it's recurrent MI or the same MI, yeah, there is a trick. But I don't want to go over MI now. My topic here is basically pericardial inflammations or pericardial problems. So pericardial inflammations, myocardial necrosis, which is 1, 2, 3, 4 days, up to 1 week maybe after MI. Now, after MI patient have chest pain, but this chest pain 1 to 2 months after MI, maybe it's positional. Hey, make sure these are non-ischemic, by the way. Don't forget, these two chest pain are non-ischemic, and the characteristics of pericardial chest pain is pain increase when patient what? I basically decrease when patient bending forward. This is usually the characteristics of the pain. So the pain decrease when forward, right? Which is bending forward. Right, so when you bend forward, basically the pain will be decreased. Now, why? Because the pericardium will not stretch. When you lie down like this, the pericardium stretched. When you stretch pericardium, you have more pain. When you go like this, right, which is bending, the pericardium less stretched, so that's why it's less pain. Now, this pericardium, so the first one, you get pericardial inflammation of the myocardium. Look at the second one, which is also really interesting. Again, this is my myocardial wall. Right. Myocardial wall is necrosis, right? So here basically you have necrosis. And this necrosis basically liberate antigens. Boom. And these antigens for one reasons will mediate immune response antibodies. Guys, whenever I'm talking about antibodies, hey, the immune system will not make antibody within 1 day, by the way. You know how many days you want to make antibodies? First, these are protein. So you will go to memory cells, or lymphocyte or plasma cells, and then antibodies are proteins. So basically, proteins, RNA, DNA, until you make a protein, and then protein will go outside. So that's why it needs time. That's why I need around 1 to 2 months. Usually, roughly, prototypical examples, I remember, yeah, typical is around 3 weeks. It's around 3 weeks questions, yeah. Around 3 weeks, I think even less than 1 month. But this is usually, it's a chronic here. So 3 weeks. Now look at these antibodies. Now these antibodies, it will come back. So it's liberated, right? And it will come back and destroy what? Boom, this layer. What is that? Pericardium. Right? Very interesting. So, sorry, will destroy pericardium. That's why I will call it immune-mediated problem. That's why I'll call it immune-mediated. So I will make it here immune-mediated cause of pericarditis. So you get immune-mediated cause of pericarditis plus inflammatory cause. So this is the immune-mediated cause of pericarditis. Please, this is the immune. And yeah, by the way, I rarely use this thick one. It's interesting. And this is the pericardial inflammation over myocardial necrosis. Maybe also you can highlight it. I like pericardial inflammation over myocardial necrosis. And this is just immune-mediated pericarditis. Now my talk is chest pain. Again, my talk is chest pain after MI. Is that okay? So that's it. This is basically our lectures. Yeah, we're almost done with the minutes. So basically this is our lecture for today, guys. Again, the big category. So far, if you'll go back to my first lectures, which is basically the first 2 lectures, let me just quickly, really quick summary. Yeah, because you need to make a story and handle the whole story with your hand. Why? Because guys, they are 7 books, please. There is no way to get these 7 books done in the day of the test. No way. You cannot. You cannot unless you make it like a story. So what we did, if you remember in the beginning, let's make it really chest pain. We got the chest pain. Yeah, that was the first lecture. Yeah, let's make a really quick revision of everything. Yeah, let's make it thin. The first lecture was chest pain, and we did with the chest pain exercise, and then finally, and then basically rest, and then rest here. And then I can say this is an increase of frequency, and then rest. And for the rest, after that, after the rest, you get 2 complications. You get shortness of breath, and you get down, or maybe each here down, yeah, you get down chest pain. This is basically our topic for 3 days. I mean, for 3 lectures. Now, if you remember, chest pain in exercise, this is the vessel wall, and this is the vessel wall basically mildly stenosis, which is not mildly, I mean 70% stenosis, so that was stable. Stable what? Angina. Right? Later on, the vessel wall will be totally, not totally disrupted, but the plaque will be disrupted. So when the plaque will be disrupted, it will be almost like this, right? This is the plaque disruptions, so that means you are talking about unstable plaque. That's why it's just unstable angina. Right? We talked about that in the first time. Now later on, the whole vessel wall will be just totally occluded by what? By again the disrupted block, because disrupted. So the whole vessel wall occluded, and when we said about the whole vessel wall occluded, that was MI. And I told you MI usually means necrosis, which is basically total obstructions, which is usually transmural, which is a Q wave, which ST elevation, right? While for those 2, it's usually ischemia, right? And usually ST depression. Now the enzymes is elevated, maybe elevated and unstable, but here the big times enzymes elevate, protypically elevate. Now that we discussed in the first slide, which is in the first 2 lectures. Now here basically it's MI complication lecture. Now shortness of breath after MI, it's really easy. You get the acute, which is 1 day, and the answer was necrosis. This is the keyword, or neutrophil, right? Which is basically edema, pulmonary edema, I mean. And you get shortness of breath within 5 to 10 days, right? Murmur positive, crackles positive, and okay. Oh, sorry. I think I need to make it. Let me see. If you'll make murmur here, yeah. Yeah, let's keep it. Murmur positive, crackle positive, then radiated, right? That was MR. Not radiated, right? That was VST. Okay? Now, again, 5 to 10 days, right? 5 to 10 days, but clear lung. Pulsus paradoxicus. The answer was tamponade. Right? Chest pain, 1 to 2 days, I mean 1 week, sorry, was 1 week, either inflammatory pericarditis, right, or recurrent MI. Now, sorry, recurrent MI. Now, chest pain, 4 weeks, which is usually, I told you, 3 weeks, is immune-mediated pericarditis. Right? So that's what we've done so far. Don't forget all of these problems, which is basically atherosclerosis. Why? Because you have another differential diagnosis. What was that? I hope you remember. What is the other differential diagnosis of those chest pain when we discuss it? Although it's not here, but don't forget, if the pathology is a spasm problem, this is differential diagnosis. If the pathology is a spasm problem, that means I'm talking about transmittal angina, right? This is transmittal. And usually it's presented as MI. So ST elevation, everything is really short duration. ST elevation, maybe Q wave, and chest pain at rest. But here was the treatment calcium channel blockers. And here is the only time that he will tell you some significant past medical history, which is different from those. I mean, not diabetic and hypertensive. So he will tell you something about spasm conditions that we discussed, either Raynaud's or maybe achalasia, or what was the third one? Raynaud, achalasia, migraine. Oh, big time. They like it. Migraine. So this is, again, guys, this is the way that usually you will study step 1. Again, I'm always insisting on these. take the whole topics together, make it a story, and bring it with you, right? Because again, 7 books, you cannot make the 7 books. You need to compress it, compress it, but keep the key point, keep the important differential diagnosis. Lung clear means what? Lung crackles means what? Is it acute pulmonary edema just acute pulmonary edema? What acute pulmonary edema means? Acute pulmonary edema basically is the symptom for a disease, which is either valvular heart disease like mitral regurg, right? Even you will see. I will talk about the aortic regurg maybe in the next lectures. I will talk about valvular heart disease. So yeah, I think this is really interesting way. And it's really fun, really a lot of fun. Always go to the common features and then try to divide the common features into what is the difference. Yeah, what is it? Like, for example, here the common is basically you get membrane crackles and you divide it whether it's membrane radiated or not. And then here you get the clear lungs. So this is the common things you get to listen to the lung. Now, that was the questions for today. I hope you like it. I hope you enjoy it. If you do, just like my videos, subscribe, and leave any comment, and send me an email. I will be more than happy to help and to work with you as usual, guys, with this step 1. Alright, so at the end I will say thank you guys for watching my videos and have a good night. Thank you.